So good evening everyone, and as you can see, my topic reads the extensive stage small cell carcinoma, a new lease of life. And the reason I have actually given this topic is because small cell is something that we kind of had ignored before, not really bothered about treating, but now thanks to new treatments, we really are looking at it in a much more interesting way. When we look at the topic today, I will talk on the treatment guidelines. I talk about the unmet need in SCLC. This is a session, definitely a lot of talk to be on the IM, right? But I will try to cover other recent developments in SCLC and see where we stand today. 15% we kind of ignore it, and so on and so forth. The majority of patients with small cell lung cancer are diagnosed with advanced disease. We typically follow the two classification from the disease group that OIA does this intensive stage treat the SCLC the treat has been traditionally platinum-based chemotherapy with or without PCI later on. Now, in the past several decades, starting from very used platinum side, in the last 20 years, there's hardly any change. There were efforts made. Irinotecan was used, we used topotecan, used the taxanes. All of them came there in the second line and so on, but nothing much is in the slide.
We can't hear you actually. Voice is missing a lot of times.
I think am I audible now?
But you have to repeat last 10-15 seconds. Yeah, now audible, but repeat last 10-15 seconds. Yeah.
So what I was saying was about the need for more efficacious treatment in SCLC, both in the world and in India. The 5-year survival has pretty dismal. It has not really improved over the past 10 years. The 5-year survival in India is around 5.9%, the 5-year is 2.4%, and the 2-year is 5.9%. So when we look at the overall requirement, now in the last 5 years, we have had certain new changes. And the biggest changes, of course, is related to the immunotherapy. In June of 2018 came the IM power 133, the atezolizumab with chemo, and in June of 2019 came the Caspian study. Both have really charted treatment of small cell lung cancer. Combining chemotherapy with immunotherapy has, combining the immuno and chemo does have potential to convert high response rate into survival. This is something that we have discussed several times as to how the combination works. It includes priming the cells, it includes priming our immune system, using PD-L1 blockade, trafficking of T cells, infiltration of T cells, and finally killing of the cancer cells by T cells. I'm not going to spend much time on it. Coming straight to the IM power 133, which is the phase 3 pivotal trial of atezolizumab in first line SCLC. Looking at certain important points. The staging used was the VALG staging to classify the extensive stage small cell lung cancer. Patients were allowed to have brain metastasis. As many as 400 patients had it. The endpoints were co-primary endpoints of PFS and OS. When you looked at the protocol used, we used atezolizumab with carboplatin etoposide for 4 cycles. Now, this is important because, as I will be showing, this was slightly different in the other studies. Why did this trial use these recommendations? There is a meta-analysis which showed that beyond 4 cycles compared to 6 cycles, there was really not much benefit when you do the extra 2 cycles. And therefore, this study used only 4 cycles. Obviously, with less chemotherapy, you have less toxicity. When you come regarding combination with carboplatin, again, there's a meta-analysis which said that carboplatin and cisplatin have almost equivalent results, but less toxicity. Something we are comfortable with, and I think this is what NSCLC has also gone with. We use cisplatin, carboplatin pretty much interchangeably. So this is what the IM power 133 used. Interestingly, PCI was permitted. However, only 44 patients received PCI. practice, I would say this is slightly lower. We do tend to give more of PCI, and that's kind of what we are used to. Consolidation radiotherapy, there's been a lot of active interest in this in the last 2 years since last year's ASCO paper, which showed that consolidation radiotherapy helps. But in this study, it's not permitted. But since it was not permitted in both the arms, it wouldn't have made a difference. However, considering practice, if we add this consolidation radiotherapy, maybe we can improve survival less more. Looking at it was around 64. Interestingly, 50% of 5 years of age. Most patients, 95%, were either current smokers or ex-smokers. Only 5% never smokers. Now, the one interesting thing is they also looked at blood-based TMBs. We do keep talking about immunotherapy, TMB, and PDL1. So this study used blood-based where they used two cutoffs, more than 10 and more than 16. When you took the cutoff as more than 16, 23% of patients had more than 16. Whereas when you took the cutoff of more than 10, it is 59%. Again, a lot of debate goes on about TMB. I'm not going to the details of it, but it's interesting that this trial tried to establish TMB and that too on the blood, not on a biopsy. When we talk of brain metastasis, like I had said, there were 8.5% patients with brain metastasis at enrollment, 38% with liver metastasis. Dr. Sachin, I hope I'm audible clearly now. There's no problem in my...
Yeah, it's fine.
Okay, thank you. Right, so to continue. I'm coming to the co-primary endpoints of overall survival. When the combination of atezolizumab was compared to the combination of only chemotherapy, the median overall survival was 12.3 months versus 10.3 months. Now, again, 2 months itself may not sound much, but in the context of small cell lung cancer, this is the first time that we are seeing overall survivals of more than 1 year. Hazard ratios of 0.7, confidence intervals, a little slayed, but still acceptable. Now, this is at a median follow-up of close to 14 months, which is pretty okay. Looking at the 12-month overall survival, 51% here, and then we of course have the updated analysis. Now, in this updated analysis, 1.5 year survival of 34%, which means 1 out of 3 patients is still going to be alive and doing well on the same protocol at 18 months. For small cell lung cancer, this is pretty remarkable. Looking at the median follow-up here, close to 2 years. So definitely one of the criticisms of immunotherapy is the shorter follow-up. For small cell lung cancer, 23 months is pretty adequate. Looking at PFS, well, like a lot of studies, PFS is not become used to with our immunotherapy. Yes, p-values very good. Look at immunity 1 month. Again, not very good. We would have liked better, but something that we have to be used to. Interestingly, this PFS advantage is still maintained with time. The difference is maintained so that at 12 months, you still have a 12.6% present, which is, again, in the context of SCLC, not bad. Looking at the overall response rates, when we looked at the median duration of response, it was 4.2 months to 3.9 with the atezo versus the chemo. The patients with ongoing response were 15% compared to the only 5% in the chemotherapy. Looking at the subgroup analysis. Now, if you look at the analysis, almost all of them tend to favor atezolizumab. The only difference being successes, which kind of goes the other way, but then look at the numbers. 368 and 35, I think that's pretty much negligible. Really cannot comment on anything or make any conclusions with small numbers. More interestingly, this becomes more interesting as we look at it. Looking at the cutoff of 10, not a huge difference. Both the groups did better. Interestingly, the TMB more than 10, even the chemotherapy is now approaching 1 year, whereas the atezolizumab is around 15 months. So, interesting, though not significant. When you look at the TMB cutoff of 16, here it is going up to 17 months. The confidence interval is just close to unity, but this is giving some indicator that probably, maybe, there is a cutoff. Again, so the number of patients is only 80 here, but this is something interesting because it potentially gives us a biomarker. However, looking at the PD-L1, now again, this analysis is a post-hoc analysis when you start looking at TMB and PD-L1, and as we have seen in across tumors, these are not really mutually inclusive. So just because you have PD-L1 high does not mean high. Looking at a cutoff of 10, when you look at a cutoff of 10, only 30%, 30% only will either have a PD-L1 high or a TMB more than 10. When we looked at the expression wise, again, looking at the number of percentage of PD-L1 on IC, this is not the routine score, this is not a normal score of tumor cells, this is a score of immune cells. More than first is and then they looked at the responses based on the PD-L1. Here, unfortunately, there is no predictive value observed for PD-L1 expression. Looking at the intent to treat, yes, there is difference, but when you start looking at the PD-L1 expression, in fact, the less than 1% seems to do slightly better than one kind of that's really acceptable clinically. When you look at 8.9%, less than 5%, more than 5%, again, no difference. Looking at the numbers, it was great. 29 people had, patients had more than 5% with a 21-month median OS, but then looking at the overall responses, I'm not going to really talk much about this and look into it, and that's what the trial has concluded, that there is no predictive value observed for PD-L1 expression. Same thing when we look at the PFS, more or less advantages maintained over all subgroups with the exception of our own brain metastasis, which is what we kind of expect. Looking at the subsequent treatments, now around 55% of patients underwent subsequent therapy in the atezo group, around 61 underwent placebo group. So 50 to 60%, and then third treatment only in 20, which kind of that this is a disease which is rapidly, and once it progresses, there's not much